to call to order the Health Committee. And to start off, I'd like to ask Councilor Garvin to give the invocation, please.
Please join me in prayer, please. Our Father in heaven, we thank you for this beautiful day. We thank you for your love and your watch care. We thank you for the way you bless our nation. We thank you especially for each one that's here this morning, especially our staff. We ask now that you would be with our military service people all over the world, and especially their families here at home. Forgive us of our sins. In Jesus' name I pray. Amen.
Amen. Next we'll have roll call.
Bradley Cobb.
Aye.
Janelle Fulbright. Here. Bill England.
Here.
Bill John Baker.
Here.
Jack Baker.
Here.
Harley Buzzard.
Here.
Julia Coates. Here. Joe Crittenden.
Here.
Jody Fishinghawk. Here. Meredith Fraley. Here. Don Garvin. Hannah Glory Jordan. Curtis Snell.
Here.
Chris Soap.
Here.
David Thornton. Kara Cowan Watts.
Honey.
We have a quorum.
Next, we're to approval of the December the 18th minutes. Is there any discussion? And I'd move for approval.
Move for approval.
I'll second. Aye. Yeah. All those in favor say aye. Aye. I thought you were trying to tell me something else. I was like, all those opposed? Approval of minutes is passed. Councilor Wangler?
Yeah, thank you, Mr. Chairman. At this time, I'd like to ask the committee to consider moving Melissa Gower to the first slot under reports.
We have a motion on the floor on the reports to move Cherokee Nation Health Services, Melissa Gower. And we have a second. All those in favor? Aye. Any opposed? Motion. Before we get to reports, I would like to take a moment as chair of the Health Committee to address some concerns. If I could take a moment. As everyone knows by now, there was an announcement made last Friday concerning the relationship between the Cherokee Nation and Hastings Hospital. Excuse me. I would like to take a moment to address some concerns that have been expressed regarding the firestorm of speculation and rumors surrounding the aforementioned announcement. First, as I hope most of you know by now, the group leader of health is here to make a formal announcement that a feasibility study will be conducted regarding a proposed change in the relationship between the Cherokee Nation and Hastings Hospital. Second, the aforementioned feasibility study is exactly what it implies. After all the pros and cons are weighed, is it feasible to change the relationship between the Cherokee Nation and Hastings Hospital? The speculation and rumors surrounding this announcement that even extends to the media gives the appearance of being divisive. Third, I would like to reiterate that this council is charged with making law and approving budgets. For someone to suggest that something as large as a change in the relationship between the Cherokee Nation and Hastings Hospital could occur without council input provides a place for fear to grow and disinformation to flourish. That being said, I would request that this council keep discussion pointed to the structure and goals of the feasibility study. I would like to point out that the purpose of the feasibility study is to uncover questions that will need to be discussed by this council at a later time regarding this proposed relationship change. What else? So, with that being said, next we have Melissa Gower from Cherokee Nation Health Services.
Good morning, everyone. Thank you, Chairman Paul, for that statement. And as you all are already aware and have been briefed, I don't know, probably 3 times now, maybe. But on Friday, January the 11th, we did make a formal announcement that we're entering into a self-governance planning process to study and look at and review the relationship between the Cherokee Nation and the Hastings, W.W. Hastings Indian Hospital. So over the next 90 to 120 days, I don't know the exact number of days, we'll be doing just that, looking at the pros and cons of each service and where they might have the best benefit, outlining the pros and cons of each, with a projected decision to be made by June the 1st. And you might say, why June the 1st? And the reason is that with Indian Health Service and self-governance, you have to allow 90 days before the beginning of a compact or annual funding agreement to negotiate and get everything in place. And so 90 days backed up from September 30th is June the 1st. So how many ever days it is between this week and May 31st, that's, I don't know if it's 90 or 120, I haven't added up the exact number of days, but somewhere around there. So I've heard 90, 120, but we'll be outlining a plan to do that. We've already started looking at various teams. We're proposing that there be people from Cherokee Nation and from Hastings on each of those teams, since they're the ones that actually know how those services are operated and what the advantages and disadvantages would be. So I look forward to the process, to the planning, and encourage your, I want your input. If you have concerns, please feel free to let us know what that is. If you have ideas about something you want to make sure that we look at in the planning process, I'd love to have that. Any input that anyone has, we want to be open with our planning process and accept that input. And I submitted my health committee,
Sorry, no, go ahead.
I submitted my health committee report in advance, so if you have any questions about that or anything else, I'll entertain those.
Are there any questions for Ms. Gower?
I have
Yes.
Melissa, I wasn't quite clear. You said June the 1st approximately. Do you complete the feasibility study, or then you'll start planning, or
No, we'll complete the planning process.
a planning process to do what?
Well, we're using synonymous terms: feasibility study, planning process. Under self-governance, the protocol is a planning process, which means a feasibility study. I mean, it's a planning process where we're going to go through. We're using those terms interchangeably to mean the same thing. So at the end of May, we will have reports with a timeline to make a decision. Are we going to assume none, some, or all of the functions?
Got it.
Thanks.
Any more questions for Ms. Gower?
Thank you. I
Thank
look
you.
forward to working with you.
Thank you.
Continue to work with you.
Next, we have Ed McLemore from Hastings Indian Medical Center.
Good morning, Mr. Chairman, members of the committee. It's good to be back. We missed the last meeting, and I apologize for that. We were engaged otherwise. I'd be happy to answer any questions you might have about our report. I think you received our report. It's a short report. It's, I think, about a 4-pager. Give you some of the data. If you have any questions about any of the recent developments, I'd be happy to answer those from our perspective.
Are there any questions for Mr. McLemore? Councilor Soap.
Yeah, I don't really have a question, Mr. McLemore. I just wanted to comment on, I had a constituent contact me looking for your contact information because they wanted to convey their appreciation and to you and your staff. Essentially, this constituent had a family member, his mother was in the hospital for, I think, several days, and she ultimately passed. But he wanted to convey his appreciation for your staff's kindness and hospitality while he was staying there with his mother. So hopefully, if you don't hear anything, I just wanted you to know firsthand that there's an appreciation out there for the work that you and your staff are doing, and the atmosphere that you create there at your facility. So much appreciation.
Well, we appreciate those comments. Of course, we do hear comments across the range of feedback, negative, positive, but we very much appreciate those kinds of feedback.
I have a question from Councilor Buzzard.
Yes, Mr. McEnroe, on your notable accomplishment, can you elaborate just a little bit more about what's going on here? I don't understand it completely. The EHR inpatient.
Okay, what we've done is the electronic health record was geared mainly to the ambulatory services that are provided throughout Indian country by the Indian Health Service. And the inpatient component involves a little bit of different record keeping than outpatient and ambulatory visits. So we've taken the inpatient component of the EHR and begun implementation effective on January the 10th with the first patient admitted using that EHR. We experienced about a 75% savings in terms of time, no medication errors. The medications were immediately available to that patient upon admission, as opposed to an average of about a 2-hour wait for pharmacy to fill those med orders with the old paper system and transmitting that information to pharmacy and then getting the medications delivered. But those medications were available upon admission of this patient, which took about 12 minutes or so for the admitting physician to complete. So this is a huge step for us in Hastings, but it is an extension of a process of implementation for the EHR that we've been engaging in since about November or so of 2004.
Well, fine. Thank you.
Another question from Councilor Baker.
Ed, I'm a little confused. Over the Christmas holiday, I had a constituent call, and the grandmother needed an MRI, and it was Christmas holiday, and they told her that she had to be checked out or released from Hastings, go down to city, be admitted, get her MRI, get checked out, and come back to Hastings. And this is an 80-something-year-old woman. And I'm just, can we not take them down there or take care of that MRI without jockeying them around?
Well, we routinely do that. It depends on the circumstances. If I recall the particular case you're talking about, I think the patient was due for release in any event. We don't provide MRIs at Hastings. We rely upon the services of another entity nearby. And we do transport those folks either through EMS or otherwise to that service. And then if they are an inpatient at Hastings and have not been discharged or released, we transport and return them to Hastings by necessity, because we don't provide MRIs at Hastings.
Well, apparently that wasn't an option for them. They had to check out, check in, check out, come back, check in.
Well, I'll have to look into that, because that should not be the case unless there was some other medical necessity for the discharge of that individual. I'll just have to get a name from you at some other point, and I'll look
Provide
into
that,
it.
yes, sir.
A question from Councilor Jordan.
Who do we need to talk to when we have a person that calls us about Hastings will pull their teeth but will not send them out to get any, like they're going to pull their front teeth, and of course, you know, they would like to try to get something in those holes. So is there any way we can, if they're not a referral out to those folks, to get a bridge or, I don't know what you would, I'm not too familiar with dental things, but
Not a dentist, so.
they need something, either I guess an implant or a bridge or lost teeth or dentures or, are we not referring them out?
Well, let me make a distinction between the referral and our guarantee to pay for the service. Because we will always, based upon medical, or in this particular case, maybe dental necessity, we will refer the patient. So based upon medical necessity, it's a professional practice requirement for the provider to actually refer the patient. But because of priority considerations, we simply don't have enough money to cover the entire range of need for all patients for every service that people need. And dental, unfortunately, is one of those services that is not really among the top priority considerations. So we will refer the patient, but we don't have the money necessarily to cover the costs of that service. So
Maybe I need Melissa to help me with this too. Melissa, is this
Gower.
something that we funded? Did we fund dentures?
We have, yes, we do dentures in our clinics, but not in Hastings, because we don't,
Okay.
Hastings is not, dental
So
is
should
not
we
one of our
tell
programs.
this person to go to a clinic? Okay, so she just needs to go to a clinic?
One of our dental clinics.
Okay, if they've already pulled her tooth, that's still our teeth, that's
She still should go to one of our clinics.
Okay, and if she's at Tahlequah, or,
Stillwell, we have dental at Salisaw, Stillwell, or Jay.
and then possibly we could get her some front teeth, possibly.
Dentures.
Or whatever you put in the spaces.
Yes, as long as she
I would-
qualifies for the program. There shouldn't be a reason why not. She just needs to call one of our dental
Okay.
clinics and make an appointment.
Okay.
Melissa, I've got more. Councilman Thornton?
Melissa, now, we do get dentures, but partials or bridges, they're not covered, are they?
I don't know. I'm not going to answer that right. I'll have to check. I think it depends on the situation, but I'm not sure.
In the front or on the back?
I don't
One
know.
shows it on the
I don't want to tell you something that's wrong, so I'll have to check with Dr. Hacker and then get back with you, but I'll do that.
No caps at all?
No, not currently.
I have another
Thank you.
I have another follow-up from Councilor Baker.
Yeah, and if you would check, because I'm of the opinion that if Hastings has pulled the two front teeth, we got to pull the rest of their teeth to give them dentures.
Okay, I'll
Good
check.
teeth, bad teeth, it doesn't matter. If they want teeth here, they've got to lose the rest of them.
I'll check.
Okay, she doesn't want all her teeth.
Let me just check and get back with you. I'll let Councilwoman Jordan and Councilman Baker and Councilman Thornton, and of course yourself, I'll check and let you know.
I have another question from Councilor Crittenden.
Okay.
Thank you, Mr. Chairman. We've talked about teeth for over 4 years, about caps and about bridges and about partials and about a lot of things for our people. And I don't know that we've ever talked about, or at least I don't remember talking about it to any extent, getting our own little plant somewhere on tribal land or whatever, where we make these things ourselves instead of going out and buying them on the market. Which would, it seems to me we could look at that and maybe do it as cheaply, much cheaper probably than what it would cost us to go out and get them. I mean, what Mr. Baker just said, I think if that's the case, that's kind of a terrible thing. You pull the front teeth and the only way to get the rest of them is pull all the others. I mean, I did that up here. But that was my choice.
But that's what's been happening.
I just think that's wrong to do that, if that's what we're doing. Just a comment, Melissa. I'd like to see us look at something like that, Mr. Chairman. See if there's any possibility of getting a plant to make our own stuff, our own dental stuff.
I think actually we did talk about that once and
And we may have.
decided that the appropriate place to discuss that was with C&B or
Could be.
the business side of the...
Yeah.
Are there any more follow-up questions for Ms. Gower? Mr. McLemore still has the floor for his report.
Sorry about
Be happy to answer any other questions. If not, I'm through with my...
Are there any more questions for Mr. McLemore?
I've got
Councilman Bowden.
one question, Mr. McLemore. On your third-party collections, I've noticed how the increase has gone up at Hastings Hospital the last years. And I guess I want to ask you how you've done that. Do you do it by more staffing or by making those collections, or how have you increased your third-party collections?
Well, I think if we were to point to a single thing that we've done to really allow us to identify those charges that we should be pursuing, it was the institution or implementation of the charge master system back in 2001. That set us on a course for identifying all of those services and charges that we should be trying to bill for. I mean, it gives us a target then. And once we did that, we started improving our system from the front end of the revenue system at patient registration all the way through to the providers, to the coding, data entry, all down through there. And then the most recent system improvement I think that we've done is create a brand new position that's being adopted throughout the Indian Health Service, Billings area, other areas are looking at Hastings' approach to what we call a business process coordinator, who essentially is the monitor, the enforcement mechanism for management from the front end, patient registration, all the way to the deposit into the bank. There is a person who manages and identifies backlogs and talks to supervisors and moves those actions forward. So I think those two things, early on, Charge Master, and then more recently, in late 2005, the creation of that business process coordinator position allowed us to consistently move up to last year $33.5 million in collections versus the appropriated monies of about $24 million, which have been fairly static over the last 10 years or so.
The other question I've got on third-party collections, I'm not sure I've got the terminology right, but say a patient comes in and the father has an insurance with the company he works for, and then the mother also works for another company. She has insurance too. Are you collecting from the mother's insurance since the father is primary? Or can you do that?
We have a system, I mean, there's a coordination of benefits set of rules that the billers and those folks, the experts, know virtually by heart, and it depends upon who is the primary and who is the secondary,
Yes.
and we consistently bill for secondary payers
So that's secondary. Okay.
throughout, either through the CMS administered programs, Medicare and Medicaid, or private insurance primary and secondary payers.
Okay. Thank you. Well, I'm impressed with the collection. Thank you.
Thank you.
I have a question for Councilman Garvin.
Yes, sir.
Ed, I know Hastings has been here a good while. Can you give us kind of a little history of how it got started and when, if you're familiar with it?
Well, it's my understanding that back in 1934 or so, there were a series of principal chiefs between 1907 and 1971 that were appointed by the President of the United States, and in some cases they were very short-term chiefs, and in case of Principal Chief Keeler, he served 20-something years, I think, 24 years or so as our principal chief. But back in 1934, there was a need identified for a healthcare facility for the Cherokee people in this location, this area. And it so happened that W.W. Hastings, William Wirt, W-I-R-T Hastings, was who had been a congressman, was appointed as our principal chief, I think only for one day, to convey title to the land that the old Hastings Hospital was on to the Indian Health Service, or back then the Bureau of Indian Affairs, that ran what was then the Indian Health Bureau. And a hospital was built. I think it had something like 70 beds back then, and then in 1984, I believe it was, this new facility was constructed or opened, and we have outgrown that. That was built to accommodate, as I recall, about 80,000 patient encounters, and we are now seeing about 244,000 or so patient encounters, patient visits throughout our system at Hastings each year. So we have not grown in space except for some very few expansions, but we've grown tremendously, 200% growth from that original projection to now. So that we're feeling all kinds of pressure for space and expanded services because people just seem to be coming in. So that's a very brief history of how we developed to where we are right now with 244,000 visits per year.
I was kind of worried about that. Also, a follow-up question, how many employees do you have at this present time, just approximately?
We have right now about 715 or so identified positions with contractors, but about 680 or so with direct hires, either commissioned officers or civil service. And of that total amount, at any given point, we typically run about 9 or 10% vacancies, a vacancy rate. So you take 680 or so and subtract 68 or so. At any given point in those ranges, we have roughly 610 to 620 employees on board at any given time.
Okay, thank you, Mr. Chairman.
Any other questions? Thank you. Appreciate it. Next, we have Jim Cousin from the Claremore Service Unit, who I believe has an announcement and an introduction.
Good morning, OCO.
Yeah.
Most of you got my email about that I was going to retire, and I have. And I'm sort of like we've not been able to touch base, and I'm sort of like, how many people saw the movie Cars? I'm sort of like Mater. I didn't get to say goodbye, so I'm good. No, bye. But I enjoyed working. I wanted to come back today and tell you that how much I enjoyed working with you these past 4 years, and working with Melissa and Dr. Grimm and Ed and his crew. It's been a pure joy. We did a lot of things in 4 years at Claremore. We had electronic health record that we modeled after Ed and built off of his successes, and I have the utmost respect for Ed McLemore and enjoyed. We both started at the same time, as you recall, and it's just been a joy to work with him, and he's an outstanding Cherokee man. We've done digital radiology at Claremore. We're poised to reconfigure the emergency room. We're on the verge of the famous OB plan, GYN plan, to get that approved and get that going. We've made technological strides. We've implemented the charge master as well there, we too are strapped for space. The facility is built in '77, the present facility, and we're just very strapped for space, and the challenge will be to how to reconfigure and how to build for the future. During the process to select a new CEO, Marty Smith, who's in charge of our credentialing office and also our CAC, clinical application coordinator, and coordinates the EHR, will be the acting CEO, and then that whole process will start again for a selection of the CEO. And again, it's been a pleasure working with you and working with Cherokee Nation. I've done it many years, and in one capacity or another, and so thank you very much.
Thank you.
Good morning, everyone.
Morning.
As you know, it's quite an honor and a privilege both to be asked to serve in the capacity of the acting CEO at Claremore. It's also a tremendous responsibility, and I take the health care of the Native American patients extremely seriously. As you know, they're going to be advertising, as Mr. Cousin said, for a CEO, so I don't have any earthly idea how long I'll be serving in this capacity, but I'll do the best I can while I'm there. As from our handout that I gave you, it was a little late in getting to you, but some of the priorities or accomplishments that I listed, we had a team receive a director's award, and we had a congestive heart failure team that is a specialty clinic at Claremore that's kind of one of a kind. And then we had one of our internal medicine doctors receive the director's award. As you know, we had the New Year's baby for Rogers County at Claremore. And to follow up with what Mr. Cousin said, in addition to some of the projects he named, just some of them that are sort of timely, or a couple that are timely for this week, is we're very near the completion of getting digital radiography in the dental department. And everything is going to digital images because of the mobility and of the image, and also because of the clarity of the image. And there's a lot goes into planning for that, but we're close to completing that project. And also on the surgery service, our Ed mentioned their outpatient EHR, electronic health record. We've been aggressively doing that for over a year now. One of the areas we have not migrated to is the surgery clinic area, and one reason we didn't is it's a little more complex to go into the outpatient surgery area, and our staffing level was down at the same time, so we were waiting for the time to be a little more opportune before we migrated into that area. So basically we still do not have the EHR in that area, or in the it's being used minimally in the emergency room area. And one big achievement to us is we recently hired a laboratory supervisor, new laboratory supervisor. That's extremely important because any physician in the room knows that how important the laboratory results are in their practice of medicine. And I believe we have a good laboratory supervisor now that's going to manage the lab well. We also, I believe, have a panel for an ambulatory care coordinator, and this person will work immediately under our clinical director and help provide guidance and supervision for some of our outpatient clinics and outpatient departments like pharmacy and laboratory. We should have a selection of that person very soon. open to questions.
Are there any questions for Mr. Smith, please? I have one from Councilor Buzzard.
Yes, Mr. Smith, and I'm not, maybe Melissa can help us with this, or whoever can, but try to get me to understand what the procedure is. I'm from Delaware County, and we have the son how to clinic here. Let me give you a scenario. The provider has a patient in there, and she feels like, or they feel like this patient needs to go to a hospital. They feel like this patient needs to go by ambulance. She calls the ambulance service, and the first question they ask this person, is it an emergency? She says, well, no, it's not really an emergency, but I really feel like this patient needs to go. If this patient takes a ambulance to the hospital, who can be responsible for paying for that ambulance visit? For the ambulance service, I guess is what I'm asking. What's happening, they're telling me that if they call the ambulance to do it, if it's not an emergency, they won't take it. They'll either come up with an excuse, say, well, you know, either our technicians are all out or ambulances are all out, so we don't have anybody to take you to the hospital. So I'm wondering now if a provider makes a discretion that they need to go to the hospital, that they can't go, or nobody will pay for the ambulance ride. Is that a policy from Indian Health Service or a policy from the nation, Melissa?
Why don't you answer that one for me? I would appreciate it.
Under that scenario, it's a contract health issue.
Yes,
okay?
that's what I understand.
So it depends on where that person's residence is and who they fall under contract health. But basically, that would have to be reported to contract health within the 72-hour time frame for an emergency, and a claim submitted for approval to pay for it.
But I think the problem is if it's not considered an emergency, and I guess the Indian Health Service is not going to pay for it if it's not the emergency. That's the problem. But the provider feels like they need to go.
I think Marty, or I'll defer to Marty or Jim about Claremore Contract Health, but for Cherokee Nation Contract Health, it still needs to be submitted under Contract Health, because it's not even ever considered for payment if it's not submitted.
Okay.
So that it needs to be notified through Contract Health that they're taking them to Hastings or Claremore, and then it will go through the approval process.
And that's basically all we can do right now. It has to go through the process to see if it's going to be approved.
Absolutely, because it's a contract health.
And then if it's turned down to the Indian Health Service on that contract, then the patient's out the dollar for going to it.
If it is Claremore or Cherokee Nation Contract Health and a claim is submitted and it's denied, then the patient can appeal. If it is still denied, and I would always encourage anyone that has an emergency contract health claim to appeal it, because 9 times out of 10, the contract health office does not have all of the appropriate records, and so they deny those. If the patient comes back and provides that information, you know, lots of times they're approved on appeal, at least in Cherokee Nation Contract Health. And then if it's...
That's where our problem is. Or I think that's where the problem is because the provider feels like they need to go to the hospital.
Mm-hmm.
It's not a true emergency to get the ambulance to take them, because if you call that ambulance, they're going to take them to the nearest health facility. They won't take them to Hastings or Claremore, because if you live in Jay, the nearest one is Grove, so that's where they take them to. But we're in kind of a catch-22.
Well, if it's not an emergency, I'm having a little bit of, and maybe I can defer to Dr. Grimm or maybe Dr. Nolan, but if it's not an emergency, I would think that they shouldn't be calling an ambulance. They should have their family members to take them to the hospital. Am I speaking correctly? If it's not a true emergency, they should not call an ambulance. Okay? So if a physician is calling an ambulance, it is an emergency. Or they wouldn't call an ambulance.
It should just be for convenience.
Now, right. Now, sometimes what might happen is, you know, there might be a different scenario where you have a patient that needs to be transported to the hospital, and they say they don't have anyone to transport them, then you get into other issues. You know, we're trying to find them a ride, we're trying to call CATS, we're trying to get the CHR to take them. I mean, there's all kinds of things there. But the scenario that you described, I can't imagine why any physician would call an ambulance if it wasn't an emergency.
Well, I've been faced with those questions there, and I'm trying to understand it just a little bit more, and you've been explaining some to me. It's just like,
And if you, what I would say is if you get a question about that, if you'll give us the name of the patient, we can look it up and make sure that, you know, nothing inappropriately was done.
well, it's just, I guess it kind of feels like, I feel like it puts the provider on the spot when they really think this person needs to go.
Well, if the provider is calling an ambulance, then it is an emergency.
Yeah, I understand. Okay, but thank you.
I'd like to interject one thing. It's a question for Melissa, just so everybody is clear. When someone goes to, this has happened in Bartlesville, someone's gone to Bartlesville, how long do they have, how many hours do they have?
72 hours.
72 hours to contact Claremore Service Unit and say, look, we've gone, okay, so it's a 72-hour window. Councilor Soap has a question. I'm not sure for Dr. Smith.
That's the question that I have is that, let's say somebody is at the prior hospital and they're being advised that their loved ones are being transported to Tulsa. The physicians are making the recommendations. Then MESTA is sending, this family this bill. The 72 hours, is there ever a review period after that, or is that just the policy? Because I wouldn't really know that.
Well, you know, once again, the 72-hour policy is pretty much what I, understand to be the time limit. But really, it's kind of like I was advised if someone asked me contract health questions is to try to get, the specifics like where the patient lives, and we'll look at each case on a case-by-case basis, and I will have someone call you back to go over that with you if you'd like. I mentioned that we got a new lab supervisor, but we also have a new contract health supervisor at Claremore, and she's really experienced in contract health services. So we all know that contract health services are both extremely important and extremely lacking at times, for what the patient needs. But really, if you want to get with me after the meeting, I'll be glad to get specifics and try to follow up on them for you.
Any more questions from the council?
Can I respond to Mr. Suggs?
Sure.
Yes. Follow up to Councilor Soap's question.
Yeah, Councilman Soap, I think your question was, is the 72-hour a policy? And the answer is yes, it is. It is an IHS policy, and because we operate the IHS Contract Health Program, it is our policy also. The reason, there's lots of reasons for that policy, but one is that there's no way of us knowing if MESTA's going to Pryor and picking up somebody and taking them to Tulsa. So we have, for emergencies, there is a 72-hour process.
Right, but as a citizen, I don't know that I would have known that I had an accident. Let's say my son has had an accident where he's in a car wreck.
Mm-hmm.
He goes to the hospital. They say, well, he needs surgery, so we're transporting him to Tulsa. My knowledge of that to follow up is usually whenever I start getting concerned about it is after the billing has taken place, 30 days later or 45 days later.
That.
It's like, well, why didn't the Cherokee Nation take care of that? Or when I go to submit it and they said, well, your deadline's a little bit past at this point in time, so I don't know if we need to advise the providers to tell people this, or if it's the citizen's responsibility and we need to put it on the website or whatever, that's a little, it's new knowledge to me, and
That's a good
I think
point.
it's a new knowledge to a lot of people that, you need to be watching out for yourself in a sense, when you come into these situations, because most of the time, I wouldn't be worried about it. I mean, 72 hours, I'm probably still going to be, just, recuperating from the shock of whatever happened that involved an ambulance.
Right, that's a really good point, actually. I don't have a good answer at this time, but it would be good to, to get that message out to everyone where they know the rules.
I have a question from Councilor Thornton.
More or less a statement of whether it's true or not. With a 72-hour notice doesn't mean that you're going to have that bill paid.
That's correct.
That's true.
It still has to go through
That's just eligibility of the program.
contract health and see
Yes.
if it can go paid or something.
Yes.
Councilor Callan Watts has a question.
Thank you. I feel like we do a relatively good job of, same as any insurance provider would, because there's the booklets with the patient's bill of rights. I think it's printed everywhere. I know with the recent accident with my husband, we have insurance, but I still had an obligation to call the insurance company as soon as Monday morning hit to find out what I did or didn't have covered and what I have responsibility for finding out about. And at St. John's, the caseworkers for each patient, whether they had insurance or not, had IHS listed and asked if you were a tribal citizen and if they needed to notify the thing. So at what point does our citizens have responsibility for themselves, or are we supposed to do everything for them? There's a balance there. So before we get too excited about changing stuff, I think we do a fairly good job of notifying, and there is ownership that they have to take too. Now, I would hope that there's an exception if a person has nobody with them. Like if I go into a coma, get shipped off to emergency room, I am only covered by Indian Health Service or Cherokee Nation, that come out 4 or 5 days later or whatever, that they would still somehow work with me, that I wasn't able to notify them in 72 hours. But otherwise, I would think somebody who has responsibility for that person would need to be calling at 8 a.m. on Monday after the thing happened or whatever to
And that's why the appeal process is in place as well. And it's so important to do the appeals.
Councilor Soap has a
Thank you, Mr.
question.
Chair.
Yeah, I was just wondering if, say like for instance, MESTA, it's in their best interest if they're aware of that policy, which they may very well be, because, the likelihood of the IHS paying is greater in some cases than, the patient paying in a timely manner. So I was just curious about that, and thank you.
Any more questions? Thank you very much. Welcome. That concludes reports. We're down to old business. I see none. New business. I see none. Are there any announcements other than the fact that the next meeting date is tentatively scheduled for February the 12th at 10 a.m.? Any more announcements?
Move for adjournment.
Second.
We have a motion to adjourn and a second. All those in favor?